So some common active range of motion exercises or mobility exercises that you'll see. Uh, uh, the knee flops, as they're commonly called, but having the patient in a hook lying position, so a supine position with the knees and hips bent so the bottoms of the feet can rest flat on the floor, and having the patient rotate the back such that their shoulders stay in contact with the floor and their knees go towards one side and then the next. So we will definitely go through these in lab when we're able to get together again. But again, these just been some very common exercises that you've likely seen. Quadruped thoracolumbar flexion extension. Again, our common term for this being our cat-cow or cat-camel. So essentially with the patient in quadruped, them arching the back up and then drooping the back down. Hook lying lumbar flexion and extension. So just having the patient, again, in that supine position with the knees and hips bent and the feet resting flat on the floor, having them flex and extend the lumbar spine only. So you might have also heard this described as pelvic tilts, having the patient go through motions, again, in a gravity minimized position. Supine knees to chest. So either one knee or both knees. Both knees tends to be described as a progression of the unilateral. And sitting, standing, flexion and extension exercises as well. So having the patient up against the wall is where I tend to start off with this and having them go through the flexion and extension of the lumbar spine. Now, not changing the whole body position here. We're talking about arching the back and drooping the back without losing contact with the wall here. Or our manual therapy interventions, strong evidence related to this particular classification as well, really wanting to gear towards our thrust manipulations, our joint mobilizations, both thrust and non-thrust, for the lumbar spine especially. And a early study here with this classification, essentially finding a 5 examination findings that were likely to identify people who would respond best to a particular lumbar manipulation. So let me change your window here. Let's look at a video. When we end up in our end position here, we'll be over the patient's pelvis like this. If we get the table up too high, it's going to make us use arms more so. Too low, we're going to be bent down. So we want to be positioned such that we'll be right over the patient, right about here. Now we're going to bring the patient's legs to the side. Bring the, if you could cross your arms across the chest. Bring the shoulders to the side. Cross the leg that's closer to us. Over the leg that's farther away from us there. And we're going to take the pelvis and get that last little bit of lateral flexion there. So bring the patient right on over towards us more so. Now, when we go into our rotation, sometimes it's easy to slip out of this position here. Make sure that you maintain your lateral flexion as you go to rotate. So this will require us to stem the patient basically along the long axis of her thoracic spine here. So as we pick her up, we're going to turn her at the same time. If the time is, we're going to rotate the patient until that pelvis comes up such that the ASIS pops into the hand. And at that point, we'll have the patient take a deep breath in. We'll take up soft tissue slack, and right when we get that firm feeling at the end, we're going to do our thrust towards the table. All right. Now you'll note that it doesn't feel too good to be in this position for a long time, so that's why I'm resetting before I actually give them the thrust. So as you're practicing on each other, you're getting into position. Keep that in mind for class as you're doing this. So I'll just do this in real time now. All right. So. Take a deep breath in and exhale. All right. So, it was a fun video, huh? Our examination findings that can be telltale signs that the patient will respond well to that particular manipulation technique were published in a clinical prediction rule. So symptoms lasting 15 days or less, no symptoms distal to the knee, so in other words, only in the back and buttock thigh area, not going below the knee. FABQ scale, less than 19, so in other words, not the work subscale, that is, but in other words, not demonstrating fear avoidance qualities. Important that we make sure we administer that test, not only to identify folks that do, but also to help us in identifying folks who would be appropriate for manipulation. And at least one hip with greater than 35 degrees of internal rotation range of motion. So in other words, essentially, this being a factor associated with positive prognosis in this particular study. So we could think of causes all day long, and it would only be speculation at the end, but we're finding correlation with clinical prediction rules, in this case, hip motion and outcome with a manipulation procedure, not causation, which is important to note. And a finding of hypomobility with at least one segment in the lumbar spine. And that was done with the prone PA in this case. So study essentially looking at these different factors, trying to validate or not validate the clinical prediction rules, found that really the important factors here, the two bolded and underlined ones. So those being the two factors most associated with positive outcomes, the duration of symptoms 15 days or less, and no symptoms distal to the knee. So again, our folks in validation studies here, validation being a very important step with the process of clinical prediction rules. Folks were randomized into either a lumbar stabilization exercise program or a manipulation group, and that's folks who were in this category. And essentially those people that fit this category who received a manipulation demonstrating better improvements, so less disability than folks who did not get the manipulation procedure, and also less likely to be getting chronic symptoms developed, long-term outcomes as well. So again, our two criteria that were strongest being symptoms less than 16 days, so 15 days or less, and those folks that didn't have symptoms distal to the knee. And those two factors alone associated with a nice positive likelihood ratio for a positive response to manipulation. So I'm sure that at some point you've got some questions that have arisen throughout our interventions here. Please don't hesitate to contact me. Shoot me an email. Let me know if you want to get some one-on-one time. And I'm happy to help out in any way I can. And thanks for hanging in there, guys.